Assalamu alaikum. Good afternoon. How are you guys? Welcome to the specialty lecture. Let's try to summarize this aspect as this title. In the program, I don't know why they put it amblyopia, no? And I got shocked, no? Because when this activity was magnified, I was saying that I was talking about this one, no? But I hope that you don't feel bad because we're not going to talk about amblyopia, no? So let's start. The question regarding this one is still valid. For us, it's normal having Botox as an option of treatment. But in the world, when you mention the word Botox, people look at you like we are crazy, especially in America. So that's why let's do a journey about the Botox and about our experience to demonstrate to the world if it is or it's not still valid. You know, like many things in science, this story starts with food. In the 18th century, appeared a pandemic of Botulinum. People started eating sausage, and suddenly one town in Germany, everybody passed away. And this guy, Justin Kerner, was a doctor, but more than doctor, was a poet. And he decided to publish and to write the findings about all these people that was passing away because they have disease due to botulinum toxin. So the first thing that this guy, the thought that came to him was, wow, we can use this because this poisoning could be related with some toxins, so we could use in some point this as a treatment. So a poet thinking in medicine and thinking in a solution. So why this is important? Well, it's important because sometimes we have artistic facilities and things, and we because we are inside of the scientific method, we forget that many things in the story of the medicine are related with events that are not related with the medicine. Okay? So this guy is responsible for this. Years later, they discover the Clostridium botulinum as a cause of these diseases. But this guy in Germany was the first guy who decided to describe this. So you are invited, if someone of you is poet, painter, musician, open your mind and probably you could find answers to the science. The next guy is this one, Dr. Alan Scott. Dr. Alan Scott recently passed away. And Dr. Alan Scott is the father of the Botox. Can you imagine the amount of plastic surgeons, general surgeons, that are using Botox today for cosmetics? Well, the first guy who used Botox was Dr. Scott. But he started in the 60s, he started using no Botox. He started testing venom of cobra. So can you imagine the outcomes, no? He was trying to use the venom of the cobra as a treatment. Why? Because the cobra venom has similar effects that the botulinum toxin. So he started injecting in monkeys, and well, he realized that most of the monkeys were passing away. Can you imagine being bitten by a cobra? So, but then he moved to botulinum and started injecting botulinum. This is the real story, and it happened in 1978. So he was the first guy who published this one and started working with this. How the Botox or the botulinum toxin works? We have basically three mechanisms. The first one is mechanical. You know, it blocks, it attacks the level of the motor plate. Also, we have other mechanisms that are related with the fusion capacity of the patient that help the effect of the mechanical. And also, we have proprioceptive factors like all the mechanisms that we call about fusional convergence, proximal convergence, accommodative convergence. All these mechanisms are helping to the mechanical effect. It's not just a mechanical effect that when you put the Botox in the face. It goes beyond of this one, okay? So this is the mechanism of action that we have from Botox. And one of the persons who did more Botox in the world at the beginning was Dr. Rosario Gomez de Liano in Madrid. And she published this nice paper, and she has been using, probably compared with in the world, Dr. Liano and we in KKH or in Saudi Arabia, we are the people who do more Botox as a treatment. So Dr. Liano published this nice paper when you can see something. Once you inject the Botox, you can see how you have an over effect at the beginning. The peak of the action of Botox happens around the 9 to 10 days. And these effects can be durable for this period of time. In average, 6 months in the case of strabismus, okay? And look at this, transient overcorrection. That's important that you keep it in your mind for the lecture that I want to tell you later. That was a long time ago. What happened after 44 years? It's still valid. Let me tell you something. The medicine is a business. You know, and we see this with passion, with compromise, but in the world today, we are in the hands of the insurance companies. And finally, we work for them. And many places, botulinum toxin is not acceptable as a treatment. They don't pay you, or they don't pay you well to treat patients with this. So in US, they prefer to go for surgery. Why? Because I'm going to get more money. It's a financial decision. It's not related with science. Okay? It's a financial decision. So what else? Who are the people who do more publications in the world? US. So because they are publishing, they are showing us the reality. Okay? So that's why the question, is it still valid? Let me tell you something. When I submit a paper related with botulinum toxin, the reviewers, usually Americans, they say, why are you using this? Why are you using a procedure that has a 30% of success? Why? No? And the reason back to this is not scientific. Probably it's related with the economical reality of each country. Just to keep it in your mind. So, it's valid. Listen, Dr. Scott passed away last year. And in 2016, he still was working with Botox. But he decided to improve, change, to see how can we improve our outcomes. So he decided, for example, in this paper, to combine the botulinum toxin with bupivacaine. Bupivacaine, not in the same muscle, in the antagonist muscle. Okay? Suppose that the bupivacaine is going to induce strength of the muscle if you inject it over it. By the way, we now are working in a randomized clinical trial. Manal is in charge of that. Today, they were discussing in the IRB, let's see and let's pray for the IRB, you know. IRB is, I'm part of the IRB committee, but IRB is like the Inquisition court. So it's a prospective randomized clinical trial, probably one of the few RCT that we have in KKH. So we want, like Dr. Scott, resemble him and test if this combination of Botox and bupivacaine has better outcomes. Okay? So, but this guy in 2016, he was keeping with the idea of the Botox, and the Botox is the commercial brand, the botulinum toxin. And now he was using this one. And look at this. When he combined using the Botox, in, let's suppose isotropia, and in the medial rectus, using the botulinum, and in the lateral rectus, using bupivacaine. Bupivacaine is using daily base in anesthesia. We use combination of lidocaine plus bupivacaine, And that's why that was the origin of this discussion. So, but basically, bupivacaine is going to induce scar in the muscle, is going to say that the muscle get more strength. Look at this. He got, in this paper, 56% of success and 66 in patients with lower degree of isotropia. Okay? When the angle is higher, he realized that the outcomes are worse. But look at these numbers, 40%, 56%. So imagine something, just move it for a moment to oncology. A treatment that gives you 50% of survival is a good treatment. You could say in strabismus, 50% is nothing. I can do surgery. I'm going to ask you something. What is the outcome of strabismus surgery?
60%.
What is the outcome? 100%? Any idea? Don't be shy. Tell me. What do you think? If I do a surgery, strabismus surgery, what is the percentage of success?
50 to 60, I think. 50 to 60%.
60, 80%? So it's not 100%. So we are curing 50, 60, 40%. So it's an interesting number. Okay? If you tell me it's 10%, well, we're not going to be wasting time with this one. But keep these numbers in your mind. So when we combine botulinum toxin, and this is an invitation for all of you, we are opening doors for new lines of research. If we combine the botulinum toxin and try to use substance that weak the muscle, like immunotoxin, this one, or growth factor, and we apply directly to the muscle, or we use substance that enhance the muscle, like the bupivacaine or like the insulin growth factor, we could see if we have improvements or not beyond of just the botulinum toxin. Okay? So keep this in your mind. It's an option. We can work on that. We do a lot of botulinum toxin here, and this is something that is an advantage compared with other places in the world. Advantage that we don't use it. Advantage that we don't show it. And if we don't publish, we don't exist. Let's see what happened now in the kingdom. We have, I brought this paper, well, it's not for you, it's from 2020, from Dr. Arif Han. Dr. Han worked with us during 12 years here, an outstanding ophthalmologist, and he presented this paper, that is a very nice paper. All of you know that when you do surgery, for example, 2 muscle surgeries, how many diopters you can correct with 2 muscle surgery? Let's suppose that you have an ET of 50. With 2 muscle is enough? No? Yes? Sleeping? Awake?
Yes, the maximum, yes.
If you have 100 ET?
2 eyes. 2 eyes.
Theoretically, if I have 100, I should do 4 muscles. Yes? As a rule of thumb, each muscle can correct 25. It's not exactly like this, but similar like this. So just imagine that you have a patient, they have this deviation. So Dr. Han did BMR, recession of bilateral medial rectus, and when he finished, he put Botox in the medial rectus. And look at the outcomes. From this patient has a wonderful, wonderful outcome. So this is an option that is here, is published, is tested. And instead of doing 4 muscle surgeries, you could do 2 muscle surgeries plus Botox as an option here in Saudi Arabia. It's common to say that when we have patients with cerebral palsy, neurological issues, delayed, we could have other options better than the surgery. Why? Because when you measure the angle, it's difficult, and cooperative patients, so we keep the botulinum toxins as a good option. This study that we did with Dr. Tagrid and Dr. Sheda between the National Guard and KKish, we found this one. We compared conventional surgery versus botulinum toxin, and look at what we found, that the surgery is better. Oh, surgery is better. It's better. We know the surgery is better, but in these cases, the outcomes were worse with Botox. However, all patients improve. All patients improve. And this is an option that we need to keep in our minds. Regarding this one, how many of us have made the questions ourselves, Doctor, what about botulinum toxin in exotropia? Many people are going to say it doesn't work. It worked. It worked very well. So there was a paper published by Dr. Seaham, and look at the outcomes when we use Botox in XT. 30%. And the most important conclusion of this paper is that the basic isotropia, the basic exotropia has better outcomes when we compare with other types of exotropia. Okay? But you see, we are using Botox in XT. It works. Probably, if we ask the preference, probably I wouldn't go as a primary option in this one, but it's an option. This is a very nice paper from Dr. Fatma Shamlan and from Khaled Al-Taibi, one of our standing fellows. They wanted to compare the dose increments in Botox according to the angle. And they divide the papers, you can see here, no? How, according to the angle, they were administering different doses, increasing the doses according to the angle. Okay? And look at this, all the patients improve, no? All improve. But they found that using small doses of 2.5 units and in small deviations, that was the better outcome and the better improvement. This is one of the conclusions of this paper. So Dr. Shamlan is proposing that Botox is dose-related. This is a hypothesis. And according to her, probably not. Let's keep moving. This is a paper that is already submitted under review, waiting to be published, that we did it here. And we made ourselves this question. Okay, is dose dependent, the doses, the botulinum toxin doses? And look at what we found in these patients. We collect all the patients who receive Botox, no? And look at from 2073 patients, 146 improved. So 50% of the patients that we put one injection of Botox, they improve. Okay? When they receive a second injection from this one, you see the numbers, how the numbers are, no? At the second time we inject less. So look at how from 50 they reduce to 34%. And when we inject a third time, 30%, but look at the numbers. Every time we were injecting 1, 2, 3 times, we see that the number of injections is not improving the outcomes beyond of the second injection. Okay? That's important to keep in our mind. So, but this is in general one of the findings that we are reporting. When we compare the doses, we divide in 3 groups. Less than 10 units, 10 to 24 units, and more than 25 units. This was the average of deviation pre-op, and the average, and post-op. And you see how, independently of the doses, the patients had similar outcomes. So it's supposed that it's no dose dependent. Okay? Clear? When we see here, and we run the ANOVA test, we found that the difference between this group and related with the change of deviation was not significant. Was not significant. Okay? So there are no difference in the doses. The patient who is going to respond is going to respond. So you could say, well, doctor, but you're saying that Dr. Shannon said 2.5 was good, and what is the idea in these stories? Is try to find the less doses to the highest result. So in this table, you can see which variables were significant regarding the factors associated with the success. And we found that the patients with a smaller angle of deviation had better outcomes. The patients with had overcorrection in the first week, so they got XT, in the long term, they showed excellent good outcomes. So something that you can read papers about Botox and you can say how many of these papers, I mean, they describe the XT as a complication. I would say today, after seeing these outcomes, that XT is a side effect. It's not a complication. And we need to start to erasing that from our mind. And you need to know this. Why? Because you're going to be in the ER. How often you receive patients in the ER with kids, with parents concerned because the kid has XT? Have you experienced this? Patient is coming to the ER telling you, doctor, we put Botox and now the kid is in XT. Well, XT is an excellent prognostic factor because in the long term, these patients are going to be straight. Do you remember the first graph about Dr. Liaño that they say at the beginning you have an over effect and then come back? This is the explanation of this one. Okay? So keep this in your mind. XT, no complication. XT, side effect, good side effect. That the angle of deviation, if the patient has a smaller angle of deviation, the outcomes, the results are going to be better. And third, patients with partial accommodative isotropia are going to respond better than patients with infantile isotropia. You need to keep this in your mind. So going back, when you see these patients and when the parents comes to the ER concerned about the XT, now you know the answer. 99% of these patients, the XT came back. We just have 1% of patients that didn't come back, and we need to do later bilateral lateral rectus recession, okay? But most of the patients are gonna have XT, and this is the best outcome that you can find in the long term. And again, if the patient had a small angle, this is better. I mean, the response is going to be much, much better than if you have higher angles. Don't get concerned about this one. It's just to explain you a little bit that these are patients, we filter the data set. And we choose patients with just received Botox, no further treatment, just Botox. And patients receive the same doses as Botox 1, 2, and 3 times. So you see 1 time, 2nd time, 3 times. This is not a definite table, it's just something that we have, that we are preparing. But you can see here how the patient had pre-op 37, improved to 27, so improved this one, and was significant. Here, using these units of Botox, improve this one, significant. Here was probably the highest, but not significant. So this table wants to tell you, okay, which dose I should use to get the better outcome, okay? So we saw at the first injection, the group who, if you tell me, for example, here, we use 11, so probably this group and this group, so using between 10 and 15 units or more than 20 at the first injection, we can have them. So, but if you tell me, if I'm getting the same result or similar result with this one or with this one, I prefer to use the smaller doses. As any medication, smaller doses, less side effects, less complications, like a general principle of any medication. So in this group, 1 the group of between 10 to 15 units. When we go to the second injection, you can see improve. Look at how interesting is that how many patients in the second injection, the changes were higher. You see at the beginning here 9, 11, but here you see 20, 20, 30. So when we do the second injection, in these patients, the effect is higher. And again, you can see how this group is the winner group. You can say, no, doctor, this one. No? But look at this one has the higher effect being significant. Okay? Second, 10 to 15 winning the race. And in the third injection, the same story. So 10 to 15 units looks like the best doses to get the best outcomes. Clear?
Regardless of the angle, sir? Regardless of the angle of deviation?
You have the angle of deviation pre and post. So we get the higher or the best improvement in the angle of deviation, or the highest difference between the pre and post with the less doses. Get my point? So this is a preliminary table. This is not nothing that is, I mean, we are working to publish this one, and we are going to do that, but this is just, I wanted to show you which one. Because I'm going to use 2.5 or I'm going to use 13. Okay? Very good. So, look at this table. It's just to try to make a graphical idea. You can see here, this is the doses of Botox, and this is the difference in the changes of the angle. No? So you can see how, when we use 10, we have highest difference when I inject it. So when I use 10, the highest, I cover from almost from 50 to -10. So, okay, you can tell me, can I use 8, 5? Yes, but look at this. The difference in the angle, in the changes of angle, is smaller. Can I use 25? Yes. I know who is using these doses, and probably if someone has been in pediatric ophthalmology knows who's responsible for this one. Is our dear professor, Dr. Botoxologist. No, that he likes to use these doses, and it's valid. It's absolutely valid. The idea when we prepared this protocol was because we have consultants in our division that they do like Fatma Shalman. According to the angle, I use doses. We have people like supradosis doctor that they use supradoses, and you have people like me that I use the same doses for all the patients. No? And at the end, the number that was giving us between 10 to 15 was near to 10. Okay? So, how many of you have been seen in the ER? R1s, R2s. Have you seen patients that comes to the ER because droppy eyelid? Yes or no?
Yes.
How many of you have received this one?
Many.
Many. And this is a lack from our side. We, as ophthalmologists, sometimes don't communicate. We don't communicate with the patient. And we forget to explain clearly. Listen, you're going to have doses, you are going to have XT, and this is normal. And we need to say this in the clinic, we need to say this in the pre-op, and we need to say this in the post-op. I'm going to tell you something. Despite of this, they are going to come back. Okay? But it's our obligation to explain clearly, because they come to the ER concerned. 100% of the patients who come with doses after Botox disappear. It's an interesting question. Okay, while the doses is there, patient can develop amblyopia? Interesting question to be raised as a research question. It's interesting. But most of the time, this doses goes away in a couple, month and a half, 2 months. Okay? So we need to keep this in our mind. When I learned to put Botox, the way that we doing in Baylor, in Texas, and then in Venezuela, was we were putting the Botox, and immediately with the mask, when we inject the Botox, we were seating the patient and keep it seated to avoid the diffusion of the Botox to the palpebral elevator. Okay? But because we know that this is not a factor, now you know the answer, and now you know what are you going to tell the families to relax and to calm down? No, explain about the ptosis. Ptosis will go away. Cakish, 2002. We saw 70,000 patients. 70,000 patients in our clinics, okay? And we performed 1,374 patients. 34% of these patients were botulinum toxin. 34% of our resources in OR, in pediatric ophthalmology, are used to treat Botox. Okay? Botox is simple, how to do it, but it's a huge, when you see, it's a number. And all of you think in medicine like something romantic, my GPA, I'm smart, you know, and again, medicine is money. And every time that you are in OR doing surgery, this is money that you are spending. And this is something that you need to keep it in your mind. Give me another suture, give me another visco, give me another. You are here because you are in Gotham City, in Disneyland. But the reality is that, doctor, you want another visco? Give me money. You spend more than 1 hour in OR, it's 2 hours. And we need to keep this in our mind when we're doing this. So when you have 34% of patients, 400, almost 500 patients of Botox, these are numbers. But let's suppose that 45% of these patients, because we say that we have a successful rate of 50%, 40%, so from this one, 212 patients were not operated. Because when we compare Botox versus surgery, we know that Botox has less risk, it's cheaper, faster, and when we have surgery, it's more complicated. So this year, we saved 200 patients to be operated. We save money, we save time. Imagine just for a second that you need to book the patient, see the patient, look at all the supplies that you are spending. So economically, Botox is a very, very interesting tool. We save 200 patients to be operated. But we can see the other side of the story. We are spending 34. If we say that this is easy and this is cheap compared with the surgery, KKH is spending 34% of our budget from something that can be performed in other hospitals. Why? Because the technique is easy to do, easy to perform. You just need a bottle. With one bottle, you can treat 5, 6 patients. So when we receive patients here for Botox, I say, wow, wow. And we receive it, welcome. But it's impacting, has an impact of 34% in our budget. So think about this. What is the message at the end? Well, if we train the people, if we teach how to use it, these patients can be treated in their locations. They don't need, just imagine the patient comes for a Botox, airplane ticket, day off of work, occupying our spaces, consuming our resources. So I'm opening the other side of the equation. Botox is efficient, yes, but also has this side of the equation that we don't see it. Okay? So with proper training, this can be done in other places. Now, small details. How can we prepare the Botox? Because it's important to know. Years ago, we were receiving the Botox like this one. And it comes in a powder. The first time that I used the Botox, this is not Botox, this is the competence of Botox. But botulinum toxin should be conserved cold, no? But the first time that I used the Botox, was an empty bottle. You say, why? I don't know if you have seen the empty bottles of Botox. Any one of you have seen? No? So come empty. It's not empty, it's lyophilized. So you don't see it. So you need to reconstitute the Botox with 0.9 saline solution, okay? So how we're going to prepare? The bottle comes with 100 units. And we are going to reconstitute this one with 2 ml of saline. This is the first thing. Here in KKH, the pharmacy do this the first step. Why is important in these cases? Because this bottle, she's carrying, I mean, she's preparing, she's going to get 2 ml. So 2 ml in 100 is going to give us 5 units per 0.1 ml. That is the standard use dosage that we use. So that is this one. Okay? So to get that one, we open the, I don't know, this lady is manipulating a lot the syringe. You know, I was scared about they get punched with the needle, you know, with the, but you open the cap, and because this one is in vacuum, you don't need to push. You just need to put the needle inside, okay? And the needle should be touching the walls to avoid turbulence, because the molecule is very unstable. And this is probably the critical step in this way. You see, you leave it alone, enter. You don't need to push, you don't need to do. And the second step is not like this one. You cannot shake it. Once we have, I don't know what happened, I think that the pharmacist was shaking or was dancing or was doing something, playing maraca, I don't know what it was doing, but you know, we have a session of Botox, of none of them had effect. So it's important, it's crucial to work with this one. You see, that's the way we're going to mix it, okay? In the case, here we exaggerate. No? They say, okay, you have 3 hours to use it. And I saw here how we throw the Botox behind 3 hours, and it's 3 hours, 5 minutes. No, this is not working. This is not like this, okay? But don't shake it and prepare it. You can use insulin syringe, okay? You can use insulin syringe, and the insulin syringe comes with from 0 to 100, no? Here is. Okay, so each line of this one is going to be 0.1. 0.1 means 5 units. So if you're going to use 10 units per muscle, so you go to 0.2. You want to use 1 syringe for one eye and 1 syringe for another eye, it's okay. Usually, personally, I use 10 and 10. I use 0.4, 0.2 in this eye, and 0.2 in this eye, and I use 1 syringe. But anyways, here in KKH also, we open the bottle and we bring in a big syringe, and we empty the needle from the big syringe, not from the bottle. But there are small ways to do it. Okay? That just to keep you updates about that one. Let's see about the technique. Ran, Abdalhan, Dr. Awad, this is the way. We usually use a Moody forceps to retract the eye, and there are many techniques. We want to enter in under the caruncle, okay? And this is important. Keep parallel to the eye, and the movement. You see how Dr. Han is moving. You can do lateral movements. One of the complications is perforation, and happen here. So careful. So you enter, you keep in this movement. Usually I touch the bone and I go back, and when I touch the bone, I recline a little bit. So you can ask me, you are not entering inside the muscle? Well, there are a lot of papers that demonstrate that you can inject inside the muscle. When I learned to do this a long time ago, I don't want to say how long, but a long time ago, we were using a transducer. A transducer, you put it, Pedro, you remember? Huh? Transducer. So when you were entering the muscle, the muscle started to see, what's this sound? But there, you can put this Botox subconch, and it's going to work as well as if you inject it in the muscle, okay? So this is the first thing. But let's suppose that we want to use it in XT. So this is another example. Botox in XT. Dr. Han is our artist. No? He's doing this. But look at this, look at the movement that he's doing, lateral movements, because if you feel that you are touching the sclera, you need to stop and going back. So if you keep this lateral movement, you see, and the patient has chemosis, and you say, wow, it's not working. Doesn't matter. Go above of the muscle, you can inject the muscle, it's going to be fine, but if you are around the muscle, it's going to be fine. Okay? And we can use it also in inferior oblique. And this is an interesting, and could be a source of research if the Botox is working in, this is Dr. Mesper, courtesy of him. So look at how is he going between the lateral and inferior rectus. He's looking for the orbital fat pad, and in this case, he's injecting 5 units. If you see if you remember the first video, you can see that the dosage was 20 units, okay? But again, you can use the dose that you want. I suggest that we can use between 10 to 15 units, precisely, okay? So, to summarize, we can use the Botox in these cases, partial anisotrophia, XT, ET. We can use it in consecutive. We can use it also in patients with palsy, 6-nerve palsy. At the beginning, the most common use was in 6-nerve palsy. In Duane, we can use to treat patients with diplopia. And also, we could treat patients with thyroid eye disease, for example. Restrictive pathology can be used. Of course, the main indication when you have a restrictive pathology is go and try to release the restriction. But it's an option, especially if the patient has high risk, variable angles, low productivity. These are the indications for Botox. Disadvantage. We have disadvantage. The patient needs more than 1 injection in average. So in average, 2 injections. And my recommendation is you inject twice. If the patient doesn't respond or the response is poor, go for surgery. Don't waste more time with Botox. We have the most dangerous, this one, and you say, hi doctor, how are you saying that you have perforation? We have perforations. And we have perforation in Kekesh. So that's important to keep this in our mind. The risk of perforation, and again, the message, if the patient doesn't improve, go for muscle surgery. Ideally, the patient should have XT. This is something that I want to insist in the complications. So entering the site, don't do like this. Why? Because when you do like this, the tip is touching the sclera. What you are doing like this is more difficult that you touch the sclera when you use bevel down. Keep this picture in your brain, tattoo in your brain. Okay? In conclusion, this is a low cost, it's very efficient. We are treating or saving the 40% of our patients, so we're saving the half of our patients from surgery, especially in centers with high number of patients. If you have your private practice, you do 1 Strabismus a month, not make any sense. But if you have centers like this one, it's a valid option. If the patient has motor fusion, be sure that the outcomes are going to be better. Again, consecutive ST is the most important thing. A small angle is another thing. Recommend those is 10 units. Look at this one. You see how many referrals we receive to treat the Botox. So these are the most expensive Botox in the world. Referral. No, I don't want to do this because, send it to Kekesh number 1, go there. Something that can be easily treated there. 1 bottle, 1 injection, 1 general OR, and that's it. This one is a choice. We have huge waiting list, so it can help us to solve the problem of the waiting list. And despite that you have 50%, okay, so 50%, but I'm saving the other 50 from surgery. So it's a valid argument. I think that is still valid. I would like to thank all these people who helped me to do this lecture. All these people work with this hard, and thank you. Any questions?